into ophthalmology. Now, at Hyderabad, we have got SIVS, that's the picture, Sindh Institute of Ophthalmology and Visual Sciences. So we are doing quite a preventive ophthalmology work, in which we are doing screening in the peripheral areas, in the peripheral districts. And that is being done in collaboration of the international NGOs. So they have, previously all the screening programs used to be done with the manual methods. Everybody, the people who were trained to check the screening, they used to know everything on the paper, and a lot of paperwork used to be done. But now this new technology, PEEK, Portable Eye Examination Kit, Portable Eye Examination Kit. This is actually a software which is inserted in a mobile phone, and mobile phone is used for the purpose of screening. Now, vision and healthcare for everyone. This is a smartphone-based vision screening program. This is an app enables non-specialist users. Non-specialist means like our ophthalmic assistants, like lady health workers, even the teachers. They can use it for the purpose of the screenings. In the communities and schools, refer people to care. And the other thing is that it is a real-time data report. What is going into the record, into the data. So it's a real-time analytics also. Similarly, at the same time, there is analysis of that. This platform shows live data, so users can see how services are being used and respond to any gap. You can see that lady health visitor, non-specialist user, screens the patients through PEEK application using the Android phone. So, now why the need arising? Actually, what happened during the first and intense phase of COVID-19, SIVS, CDM, and PEEK initiated. PEEK is a program used by the international NGOs. So, with the collaboration of that, they initiated a paperless eye screening project during the year 2020. It connects the primary tertiary level. Now, we are at the SIVS at the tertiary level. We are in the districts, and then there are primary levels in which there are basic health units. There are basic health units, rural health units, taluka hospitals, district headquarters hospitals, and the tertiary at SIVS. And along with that, the hospitals, the school eye health screening, in addition to community eye health screening, same technology has been adopted to screen more than 150,000 school children in the district Matiyari, which is a peripheral district. Now that is the patient workflow. How did it work? The health facilities connected through application. There were 24 basic health units, 5 rural health centers, 3 PHQs, district hospitals, and tertiary eye hospitals. Technology users were 27 Medihealth visitors, they were the screeners, and 7 optometrists. They were the tri-edge level. So in the community, the screening was done by lady health workers and social organizers, and they got appointment dates, and then the patient were referred to the basic health units, where community eye health screening was taking place by the lady health workers, lady health visitors. Lady health workers, they sensitized in the community, house to house. Then they were taking the basic health unit, where the lady health visitors were there. They screened it, all the people, they were screened by the mobile phone PEEK technology, and they were referred to the rural health centers, primary health centers, and the refractive services, where they were the optometrists were available, and then they were from there they were referred to the secondary hospital PHQs or direct to the tertiary hospital, depending on the disease process or whatever they got. They were refractive where people were directly referred. They were not referred to the secondary or tertiary hospital. They were referred to the optical services where they got the classes. So this was actually patient workflow, and it worked very nicely. Progression. This is the data I will share with you about that. So progress at the screen. This is about 7 September. It started 7 September 2020, and data is up to 30th September 2022. Up till now, total patient screening was 164,690, and total patients outcome positive means who have got some ocular pathology. They were the number of the people screened, and the number of the patients who were found 39%, they had some ocular pathology. So this is the data. And then total patient who were referred from the screening level was 60,545, and the total patient received. Now they were sent to the Taluka hospital and at the triage level where there is optometrists were there. So you can see that out of 60,000, all the patients they were received at the basic hospital. 96% was the referral case, which is a very, very good. So the patients had the confidence in the system that all of them they came in there. Then, as I told you that we divided majority of the patients for the refractive errors and the pathology patients. We separated. Pathology, patients having pathology, they went to the Taluka hospital or the tertiary care hospital. Refractive error, they were not sent to the hospital, they were sent to the opticians for the glasses, and they were giving them prescribed glasses. And they were sorted out. So you see, we know that major common problem in the community is the refractive error. And particularly the rural areas, they don't have access to the glasses and they don't find it. So total glasses they were prescribed free of cost. The total glasses prescribed 17,052, and out of them this number 18% were prescribed free of cost because they couldn't afford that. Then now the patients were the pathology. They went to the total being referred to the THQ and DHQ level 48,000. And then out of that, the referral was 5,848 received there. So that is about 72% they were received there. And total patient referred tertiary care 913. Out of that, they were registered in the tertiary care 380, 42%. As the tertiary care hospital was slightly away, so it was not easy for every patient to come there. So that's why the referral rate is slightly lower here. Is DHQ slightly higher there. So this was the eye conditions which you can see in our community, that the majority of the maximum number was this, which is the conjunctivitis related to it, which is about this amount, and then cataract for 8,059, 13%, 28% was this, and this is the remaining data which you can see about. So this is how the program is still continuing, running, and we are screening and getting the real-time data, and we have tested this technology, and there's least chance of error in this because no paperwork. Human error is common in the paperwork. We can make mistakes. Some people can do mischief. They can put the wrong data, but here there is a real-time data. So this is a very successful screening program going on. It is continuously and very successfully going on. We have got future planning for our screening program as well, in which we are going to establish tele-ophthalmology, the district approach, and peak programs in the different Pakistan areas as well. We are going to introduce artificial intelligence. We are planning for that, AI, particularly for the diabetic retinopathy screening programs. And also peak to be made. Now the peak to be made part primary eye care projects in SS and in ASK and other areas as well. They are the parts of the same in different parts of the same. So what we believe in that the prevention is better than cure, and now the whole world is going towards the prevention, rather prevent the disease rather than cure, because we cannot cure the patient because we don't have that much human resource, that much logistics available. We have to pay attention to the screening and minimize the disease so that we can serve our community and prevent the blindness. Thank you very much.